Thank you, Chief Madam. First of all, I will convey my thanks to the organizers for this opportunity to speak about my favorite topic, adipose tissue, bench to bedside. Adipose tissue is the largest endocrine organ of the body, and the beauty of this organ is that this can adapt to size according to requirement, and it plays several physiologic roles, but the most important is energy homeostasis. The paradox of the adipose tissue is both too less and too much is hazardous. Lipodystrophy, when there is almost no adipose tissue, when there is no little fat, it is worse than even simple obesity. And of course, the excess of the fat is associated with. Up to this slide, I will say excess of fat is associated with heightened risk of vascular and metabolic diseases. By the way, next slide I will not use this term of association. And you all know these facts. Adipose tissue expansion not only lead to quantitative change but also qualitative change. This is very important. Whenever there is an expansion of the adipose tissue, we generally believed, it was believed say decades ago, that expansion of tissue means more and more same time of tissue, there is no change in the quality. Now it has been realized that this is the change in the quality as well, and the quality is the most important change, not only the quantity. Location and quality is more important than the amount of fat. And these qualitative changes, they are shown in picture. I will tell what exactly they are at, tissue level. These quality changes can cause fat to become pathologic or sick fat. A good quality fat and bad quality fat. The whole story is around this quality of the fat. And another adipose tissue paradox is this: not all overweight patients develop metabolic disease, and not all patients with metabolic disease are overweight. So linking all disease to obesity is not true, but we should take into account its location and its quality. And currently it has been classified that weight gain could lead to simple obesity or expansion or pathologic or sick fat, so-called adiposopathy. There could be two types of fat expansion. One in which there is a derangement of endocrine and immune responses, which leads to sick fat disease or adiposopathy or pathologic adipose tissue, which will lead to increased risk of elevated blood glucose, elevated blood pressure, dyslipidemia and other metabolic disorder. The other type of fat expansion, which is only increase in abnormal and pathologic physical forces, except the weight of the fat is increased, it will lead to fat mass disease, which lead to stress on weight bearing joints like osteoarthritis, immobility, tissue compression can cause sleep apnea, gastrointestinal reflux, and tissue friction like intertrigosis, etc. So whenever there is a weight gain, one should differentiate whether it is a pathological or a only physical weight gain. The pathologic gain can be minimum, can lead to big disease. So a obese can be healthy and a non-obese can be unhealthy. Now, question is, I told in the last slide that association of obesity with disease. Now it is realized, it has been recommended that adiposopathy, sick fat should be a primary disease, and other metabolic disease are manifestation of disease. Like your cardiomyopathy, nephropathy. Nephropathy can lead to congestive heart failure, but primary disease is nephropathy. Cardiomyopathy, primary defect in your adipose tissue. This can lead, defect in the myocardium. This can lead to even hypoxia. So that is consequence of that. So adiposopathy as the primary cause of most cases of metabolic disease such as high glucose level, high blood pressure and dyslipidemia, as well as most cases of CVD. So what I want to remind again here, that adiposopathy is the primary disease, and diabetes, hypertension, dyslipidemia, vascular disease are manifestations of this disease, and this is the concept of adiposopathy or sick fat disease. So what we need to translate this into our practice, we need to generate good data that whenever a patient comes with diabetes, hypertension, dyslipidemia, we should start adiposopathy patient. Because there, I will show in my last slide just an overview that the future is coming when we will treat adiposopathy itself rather than treating diabetes, hypertension separately. We must treat them separately, but there will be avenues to treat adiposopathy directly. That's why we should bring the concept of adiposopathy into our practice. Is now coming to a very pertinent question to our population. I am coming to this point even before I am describing in detail of the adiposopathy, that Asian Indian phenotype, is it adiposopathy? That is a very important question before me. And association of obesity with diabetes known in Indian populations in ancient times. And we know all about Asian Indian phenotype. Therefore, they have relatively lower BMI. They have more fat. We are hearing this story for many years, and this is where, as you said, they have ectopic fat deposition, high insulin resistance, high prevalence of metabolic syndrome, and higher prevalence of diabetes and atherosclerotic disease attributed to it. We all see review about Indian population. Indians have high risk of diabetes because they have more fat. Everywhere we read about it. When I look into the data, these are the landmark studies which established the concept of Asian Indian high fat content. They compared Asian Indian non-diabetics with other Asian group non-diabetics. They are not comparing diabetic or metabolic syndrome with other. And they find that Asian Indians have higher amount of fat content, and there was amount of visceral fat and higher amount of insulin resistance, but not higher BMI. But visceral fat volume was definitely correlated with their high insulin resistance. But visceral fat volume only partly explained high insulin resistance. So even though this study is established the concept of Asian Indian phenotype, visceral fat and all these things, whatever the finding, this one only partially explaining their higher insulin resistance, not completely. So it raised a question, is it quality or quantity which links visceral fat to insulin resistance? In another study which was from Manisha Chandalia and group, that even when corrected for higher body fat content, Asian Indians have higher insulin resistance. That means as compared to other racial group, Asian Indian, even when corrected for excess of fat, definitely they were excess of fat, even they had a high insulin resistance, high fatty slugs. So this also suggests that it is not only the quantity, quality of fat also influences insulin resistance. With these findings, I am now coming to the landmark study, Dr. Balasubramanian, this is your study, well quoted, that Asian Indians have high visceral fat content and well quoted study. But I looked into 2-3 more aspects of the study that percentage of body fat by DEXA with diabetic, non-diabetes was not very different, and even only central fat was high. Overall adiposity was not high in diabetics. So looking for diabetic as a whole, now I am comparing Asian Indian diabetic with non-diabetic. We talk. Your study said diabetes do not have excess body fat. It is only the visceral fat which is excess. I think there was a good correlation, but what was the definitely overall effect? That was not great. And we did one very simple experiment, and this is that we compare body fat content by DEXA of diabetics and non-diabetics belonging to the same family. We did not compare a group coming from Kachi Basti and other group coming from affluent society, but we compare from the basically husband, wife and same family because they are no same economic group. And what we observed that diabetic, despite high insulin resistance, had comparable overall adipose tissue mass and peculiar body composition comprising of higher trunk lean mass. Diabetics have higher trunk lean mass. Association HOMA are with lean mass instead of adipose tissue mass as seen in control in diabetics need further investigation. That means diabetics when compared to non-diabetic from same family, I mean to mostly husband or wife, but not brother sister, and they had comparable body fat content. We did not especially look for visceral fat. Definitely this is the limitation of the study, but HOMA are correlated with lean mass, particularly trunk lean mass, because your liver ectopic fat is basically measured as a lean mass in your DEXA study. So this suggests ectopic fat deposition. This is not the basically total amount of fat which is important. And it has been hypothesized around a decade ago why might South Indians be so susceptible to central obesity and its atherogenic consequences, the adipose tissue overflow hypothesis. That means they hypothesized that the superficial subcutaneous adipose tissue compartment is larger in whites than in South Asians. If so, as obesity develops, South Asian exhaust the storage capacity of their superficial subcutaneous adipose tissue compartment before whites do, and that is why they develop the metabolic complications of upper body obesity at lower absolute mass of adipose tissue than white people. So this is basically their limiting of the storing capacity of subcutaneous tissue to fat. That's why it goes deposed in the ectopic location. So now say whether there is defect in adipose tissue, I find that amount is not very different, but I am not talking of visceral fat. Now this difference is in quality is there or not. Issue is whether there is a qualitative defect or not. So I look into literature because I have access to microarray technology. So look for micro evidence of role of pathologic adipose tissue in resistance, and I find so many evidence other populations. The diabetics, when they become obese, when they are compared to non-diabetic, visceral vessels, they were compared, and they find there were qualitative changes. And microarray is a powerful technique to not only say there are difference, but what are the difference in the molecular function. So same time we can find there are qualitative changes, same time we can find a microarray the basically what is the molecular basis of that. At least we can generate a hypothesis of that. So when we compare this study, we took actually obese, diabetic and non-diabetic women to remove the other confounding factor. Both the group are comparable in BMI. We took visceral adipose tissue biopsies. So amount of fat was same, BMI was same, but we did a transcription profiling of visceral adipose tissue from two types of women. One was diabetic, other was non-diabetic. We find up and down regulation of several of the genes. Almost 18-20 genes were upregulated and around 6-7 genes were downregulated. When submitted these transcription differential data into bioinformatics tools, we find whereas genes upregulated a diabetic showed enrichment of natural killer cell mediated cytotoxicity, the downregulated gene showed enrichment of biosynthesis of unsaturated fatty acid. Given the known inhibitory effect of unsaturated fatty acid on inflammation and natural killer cell number and activity, our results suggest that visceral inflammation resulting from decreased level of unsaturated fatty acid may underlie progression of diabetes in obese individual. So this data I am not establishing but suggesting, I am still saying this is a suggestive, that there are qualitative changes in the visceral adipose tissue of those who develop diabetes. Still not clear whether it was consequence of diabetes or what is the cause of diabetes, because that is, we are answering another project now. So at least qualitative differences are definitely there. They are in terms of metabolic defect as well as your inflammation. Both the times problems are there. Heightened inflammation and decreased unsaturated fatty acid synthesis. In another study, we looked for the effect of pioglitazone on body composition. And you know, your limb fat is said to be a protective fat, and I also mentioned in the overflow theory that this less storing capacity in the limb in subcutaneous tissue will lead to ectopic deposition. The same thing in mind, we study the effect of pioglitazone for 6 months on body composition, and very interestingly we observed that pioglitazone alters body composition by increasing limb fat content without altering trunk fat. It is important. The increased limb fat, its glycemic response as well as HbA1c reduction, I am not mentioning in this abstract, is associated with increase in limb fat. So this is proving the concept, the less fat in the limb, if you increasing by adipogenesis, this will lead to decrease in HOMA-R and glycemic control, because they were treatment naive patients, newly diagnosed patients. Disease was early. Now actually preparing full text of this article, this work, and we will publish it. So, but this is proving by intervention that less fat in the limb, if we expand the limb fat, it will take away the ectopic fat, or whatever way it improves your insulin resistance, it makes it normalization. In fact, we compared with control group with the non-diabetic, it became comparable, HOMA-R in both the groups. So, this strongly suggests that less fat in limb is pathogenic in Asian Indians. So with this thing in background, we did one experiment. This is still an ongoing study. I have just preliminary data here. We took biopsies from thigh of diabetics and non-diabetics, both two groups. So we have so far, which is an ongoing project, 13 biopsies from diabetics and 27 biopsies from non-diabetics. So we did genome-wide gene expression profiling in my own lab, because we have a FE matrix platform with us. And we find there was no major difference. Heat map showed not major difference. A few genes are showing alteration, but the 3 genes were B cell differentiation related gene. There was a nominal difference in the expression level. They were down-regulated. The 3 genes in this process down-regulated set. These genes are GPR183, PIK3R1 and VCAM1. These 3 genes were showing nominal down-regulation. Of these 3 genes, PIK3R1 looks interesting, because this gene encodes 85 kilodalton regulated subunit of your PI3K. You know, phosphatidylinoinositide 3 kinase. This is an important insulin signal transduction molecule in your insulin signal transduction, and its regulatory unit is down-regulated. If its regulatory unit is down-regulated, because it is playing an important role in metabolic action of insulin, and its mutation in its gene has been associated with insulin resistance. This is well known. And short syndrome is a condition when there is one of the mutation in this gene found to be associated with severe lipodystrophy. So my finding in this study, this is still an ongoing study, this is a preliminary result, that this PI3K regulatory subunit downregulation could play an important role in insulin resistance at limb fat. And you know, your this adipogenesis or this fatty acids triglyceride synthesis depends on insulin. If there is a inhibition of insulin transduction because of this mechanism, there will be no storage of triglyceride in your fat tissue of the limbs. That's why it spills over. So this is the hypothesis coming out of this stage, an area where we can work further and prove this concept, and this could be a new molecular target for anti-diabetic drug development for our population. So now coming to the pathologic changes in adipose tissue, I think I will have to go very fast. There are four, visceral adipose tissue, whatever it is, I have got 4, 5, 6 slides, but crux is that the pathologic adipose tissue is having adipocyte hypertrophy, they have lot of fibrosis, and they have M1 macrophage infiltration. There is an increased number of macrophage infiltration, and their polarity changes to M1. Actually, I will skip because time constraint. So this is the crux of pathologic change of pathologic adipose tissue. But I find in limb Asian India it's different, because this data I have not shown because it is under a process. That diabetics have very small size adipocytes as compared to non-diabetics. But because this is under process my project, so I have not shown my results here. But classically say diabetics, when they say pathologic adipose tissue, its 5 characteristics are there. That is infiltration by macrophages, adipocyte hypertrophy, angiogenesis failure, matrix defects, and crosstalk and ectopic fat deposition. And this has proved to be correlated with their actually HOMA-R and their clinical phenotype also. Actually, I can skip these slides. There are several mechanisms explained why the adipocytes macrophage infiltration is in the cell, and this polarity is very important component of your sick fat or pathologic fat. And other immune cell have been implicated, right from your mast cell even have been implicated, other type of macrophage, other type of your inflammatory cell like natural killer cell, all other have been implicated. In fact, this is an area of interest wherein immune cells play a role in adipose tissue pathology. Another defect of adiposopathy is adipocyte hypertrophy. Adipocytes are derived from mesenchymal stem cell. They are recruited whenever there is a positive carrier rebalance. They undergo stem cell proliferation, then become pre-adipocyte and finally differential adipocytes. So this is a process to accommodate more and more fat. And adipogenesis is controlled by number of transcription factor. So actually in this area we have now started new project. We have our stem cell lab. We are taking mesenchymal cell from adipose tissue biopsy of diabetics and non-diabetics, and we are going to develop the cell line. Actually, we already funded, everything is ready, reagents already purchased, and we have done a successful experiment with pulp, mesenchymal cell from dental pulp. We are able to grow the cell lines. Now we will do from adipose tissue of the abdomen. We will take biopsy from surgery, and it is open for all of us. You want to collaborate, we can collaborate. And those lines, you can study those lines, and we can look for specific targets, specific molecular target to our population. So adipogenesis, poor adipogenesis means lack of hyperplasia of the cell. This will lead to hypertrophic cell, their limited capacity and leading to adipocyte stress. Another defect is poor angiogenesis. Whenever there is expansion adipose, there is a concurrent, there is an angiogenesis which increase the vascularity of the tissue. If there is angiogenesis failure, this will lead to stress and ischemia and damage of the adipose tissue. This is shown here, is form. I can omit this slide. There are also matrix defects. Metalloprotein defects are there. Now coming to pathophysiology. The pathophysiology of sick fat is that whenever there is an adipocyte stress, there is a more and more release of your free fatty acid. They act on toll-like receptor of your macrophages. Toll-like receptor activation of macrophage, this will lead to TNF-alpha, which will lead to further inflammation of the cell and more fatty acid release. So there is a vicious cycle. And this more fatty acid and inflammatory marker lead to ectopic fat deposition and stress, and all these pathologies, your ceramide induced or ROS induced inflammation, HIF1 induced, and all these inflammation effects are there in the peripheral tissue like liver, muscle, and other organs of the body, including pancreatic beta cell. Now coming to the etiology of adiposopathy. This is a polygenic disorder. This is caused by environmental factor as well as your genetic factor. Regarding genetic factor, in a brief, I will tell you that Dupine did this work in identifying the genes by Jiva in Indian population. But we don't know how these genes could contribute to our adiposopathy. that they play a role, because generally it is believed the genes which are influencing insulin Jiva genes of type 2 diabetes influence insulin secretion. This is a well-known fact. Reviews are there from McCarthy on this subject. And obesity genes are affect hypothalamic function. So far there is no evidence that genes which are added in Jiva influence insulin adiposopathy. So similarly genes which are related to obesity, FTO gene which was found to be linked to obesity, not to diabetes in our population. This suggests that diabetes is not related to simple obesity. Similarly, two genes which were identified in this dopamine and our group, that's SLAM F1 and ITLN1, these two genes were inflammation relief and they were showing association with diabetes in our population. So all this evidence suggests this is more related to quality of fat rather than the quantity of fat. So we did a system biology approach to reveal what is the role of Jiva gene which we identify in Jiva in your causation of Asian Indian adipose tissue pathology. So we took adipose tissue biology and we were interestingly find.
Sandeep, I'm afraid you've lost your time.
1 minute only. That the genes which are identified in Jiva in our population in dopamine indigo study, their interact was altered expression in adipose tissue. That's why it is believed that those genes which are associated with diabetes possibly playing a role in diabetes adipose tissue pathology in our population. Now some studies suggest role of methylation defect. We also find an association between environmental toxin bisphenol A and adiposopathy by relationship with HOMA-R as well as adipocytokine expression. Now coming to the clinical application, I think I will have only one slide. There are so many clinical conditions which could be related to adiposopathy, not only diabetes, hypertension, SUVD, polycystic ovarian disease, hyperuricemia coli, glomerulopathy, growth hormone, all these things. Now coming to treatment part, weight reduction definitely there by diet exercise. Then bariatric surgery does much more than weight reduction. It has a effect on the pathology of adipose tissue. Similarly, inflammation can be affected by so many bioactive compounds. This is important because if adiposopathy diagnosed early, one can intervene with lifestyle measures like more of this curcumin, resveratrol and this green tea and other things. And pharmacotherapy had established definitely role because treatment will succinate, which is anti-inflammatory drug, decrease insulin resistance, improve hyperglycemia. This is a proof of the concept that treating adiposopathy directly can help in control of diabetes and hypertension. Not only it has opened the avenue for so many new targets of adiposopathy drug. So in future we may get a good drug which will take care of adiposopathy and indirectly take care of all these your vascular metabolic disorders. So thank you very much for your kind attention.